Um, Dr. Elena Santiago from Clinica Tambre, thank you so much for giving up your time this afternoon. I know you're very, very busy in clinic, so it means so much to us for you, to have your precious time.
Thank you so much. Thank you for inviting me today. And I'm absolutely delighted to answer your questions.
Oh, thank you. Well, today I just wanted to focus really on the crucial day of transfer. It's the day that the day that everybody's worked up towards, the day of transferring that embryo. And so today I just wanted to ask you, I've got a few questions that I want to get through, but can you just start by explaining what, as a doctor, have you sort of tried to achieve up to the point of transfer, just in terms of the embryo and the lining? Can you, explain what you've done?
Okay, absolutely. So obviously we have two very important things, no? The embryo and the endometrium. The embryo is going to grow in the lab in the perfect conditions. This means atmospheric conditions, temperature, such as the uterus. And we have to see that the development is correct throughout the days. We normally recommend the transfer in day 5 or day 6, which is the blastocyst stage, so that we can have the highest success rate. We have to see also that the quality of the embryo obviously is correct. This means that it has a minimum quality to have the correct success rates. If not, we are not going to do the transfer at all. And by the endometrium, we have to see with the ultrasounds that the uterus obviously is normal, that there are normal formations, that the endometrium is, we say, trilaminar, which is, sorry.
You say trilaminar? What does that word mean?
It means that we see in the scan 3 layers, because this is when the endometrium is like in the first stage of the cycle. Okay, so we measure the endometrium and we see that the aspect is trilaminar, and this means that it's good for an embryo transfer 5 days after adding up the progesterone.
Okay. So
because with the sorry.
No, I mustn't interrupt. Carry on.
No, I was going to say that it's true that the transfer day, the endometrium is not going to be trilaminar. The aspect will be different. But we say that when we prepare that endometrium, it has to be trilaminar before adding up the progesterone.
And so you're looking for this blastocyst. Can I just go back to that point then? Can you explain what a blastocyst is? Because I could never get my head around this when I was going through IVF. What is a blastocyst?
Okay. It's an embryo in day 5 or 6 that has loads and loads of cells. It's very different to an embryo in day 2 or 3, where they only have like 8, 10, 12 cells maximum. So here we are talking about hundreds of cells. The proper embryo has done like an expansion where we can see different structures that they are called the inner cell mass, where the proper embryo is going to grow. And outside we have like a ball with loads and loads of cells surrounding the inner mass. And this ball is called the trophoblast or trophoectoderm. And that will be the placenta during the pregnancy.
Wow. Well, I always see in lots of forums, and we get lots of emails as well, the question, day 5 or day 6. So what is the big difference between 5 or 6? So 6, is 6 like the best one? Is 6 the best day?
No, it doesn't mean best 5 or 6. It only is different depending on the embryo, because sometimes they achieve the blastocyst stage a little bit earlier or a little bit later. So the important thing is to find out when the blastocyst is expanded and has, let's say, a correct stage to be transferred.
Okay, so you've got your embryo, let's to that perfect stage. So your embryo is ready, and then you've got your endometrium, which is you know, you've made sure it's the correct thickness. There is a correct? Another thing I remember is fixating on this thickness. What should it? Is there a specific?
Yeah, by the studies we've seen in all these years studying the thickness of endometrium, the best would be to have a minimum of 7 to 8 millimeters and maximum of about 14, not more. And it doesn't mean that if I have 10, it's better than 7. It means that from 7 to 8 onwards, it should be correct.
And is there anything that you can do as a woman yourself to prepare that lining? Is, you know, to sort of to maximize its receptivity, if you like?
Truly not. I mean, there's no such recommendation in maybe daily habits to improve the endometrium. It depends on the hormones that the proper ovary are creating, no? During the IVF, the stimulation, or when we're doing, for example, an embryo transfer of a thawed embryo, we are putting those hormones with pills or with patches. So obviously it depends more on the medication or the proper hormones than anything else.
Because I think a lot of women give themselves a very hard time because they feel as though they have done something wrong when it comes to, you know, implant failure, and so we constantly get the question, what can I do? What can I do? And you've just explained there's nothing really you can do. You're in the hands of the doctor at this stage, aren't you?
That's it. The important thing is to make sure that we have the correct endometrium, as we said, that there is no other images such as polyps or fibroids that could avoid an implantation. That's important, that the doctor is seeing properly the ultrasound and discarding any of these, let's say, polyps or fibroids. And it's important too to normally see that the hormones in our body are correct. Mm-hmm. This means that we have to do also a blood test before the transfer to see that progesterone levels are low before adding up the progesterone pessaries or shots.
Mm-hmm. And what would you do for a woman who's or a couple whose embryo hasn't quite reached day 5 or day 6 and it doesn't look like it's getting there? Do you transfer earlier?
Normally not. Our recommendation is always to try and achieve a blastocyst, because putting or transferring an embryo in day 2 or 3, if we are seeing that they normally stop naturally at the lab, this is going to happen exactly the same in the uterus.
Yeah.
So for us, it doesn't have any meaning, no? I mean, why are we going to transfer an embryo earlier if chances are going to be even lower? Yeah. So it's preferable that we wait until we see if we achieve that blastocyst, and if not, then we'll see. Maybe we have to change something else in the treatment, or sometimes we have to go through a different treatment.
And what about if a woman can't get to the optimum thickness of her endometrium? what do you do in those circumstances? What if she was just like a tiny little bit thinner than it should be?
Yeah. Okay. Yeah. Normally, what we do is cancel the preparation. If she was going through an ovarian stimulation, what we do is freeze the embryos and do the transfer at another time when the endometrium is correct.
Yeah.
If it's an endometrial preparation for embryo thawing, then we just cancel it and start again and see if we can achieve the correct endometrium.
Yeah.
If we've tried 2 or 3 times with medication or natural cycle, it's like another option, and we are not getting there, then maybe we have to do more tests, such as, for example, a hysteroscopy to see the uterus, if there is any problem, have biopsies to see if there is something else there that we are not seeing.
Actually, one other thing, I mean, it's another big topic, but I'd love to just ask you now. Some clinics prefer to actually freeze embryos, don't they, anyway, and transfer them later. So do you have a preference, though, between fresh and frozen, or does it purely depend on the patient?
It purely depends on the patient in our case. I mean, if we have everything correct, there is no risks for the patient, or there are no hormonal problems, endometrium problems, then we go ahead with a fresh transfer. But obviously, the minimum is going to take us to freezing the embryos, because, I mean, it works exactly the same. So if we need a better preparation to have the best chances, then we are going to stop and prepare the patient again.
Okay, and I've heard about the ER, is it the ERA test, the endometrium?
Yeah.
Yeah,
perfect. Yeah.
So if that test, well, would you explain what that test is? Because you'll explain it far better than I.
Yeah, sure. This is a test that what it does with an endometrial biopsy, genetically, they test whether our window of implantation is correct at that time. This is because we've seen that the endometrium really is going to be receptive in about 2 to 3 days. And testing many women at the same point of the transfer, they've seen that about 10% of those women had, let's say, a changed window of implantation, meaning that maybe their window was before that time or after that time. So it's as easy as doing an endometrial preparation with medication or in a natural cycle. We do the biopsy at the exact time of what it was going to be the transfer, let's say. It's like a testing transfer. We do the biopsy and send it to the lab. And then in about 10 days, they tell us whether the window of implantation is correct in that patient. They say it's receptive, or whether that window is pre-receptive or post-receptive. This only means that we should change the hours of progesterone before the transfer for those patients.
When you describe it like that, the human body is so phenomenal, isn't it? The fact that there is a certain window where your endometrium is ready to like collect that embryo. It's completely mind-blowing, actually. It's completely mind-blowing.
Absolutely.
So would you say that, so is that does that test enhance your chances then of implantation? And if so, would you recommend most people to have it?
Obviously, it's going to assure us whether we are doing the transfer at the correct time or whether we have to change it, no? So it's going to optimize the results in each patient. Obviously, when patients come and want to do the treatments, they are many times in a rush and they don't want to go through many tests before starting. But it's true that the latest scientific research in the ERA test tell us that we should do it to absolutely every patient, even before starting with the stimulation. I mean, it's very, very important. And well, we always tell them about it, recommend it, but obviously it's something that normally we use when there is an implantation failure, not at the start.
So, and actually, so what I wanted to come on to next was, so if your endometrium is perfect, your embryo is day 6,
or day 5.
Or day 5, sorry, I must get over the day 6 thing, or day 5.
Yeah.
And it still doesn't implant. Like, why? I mean, I know it's the $1 million question, but why would it
Absolutely.
why would it not work?
I mean, there are many, many, many things that we can't see and that we even can't know what is happening there. There has to be like many chemical reactions in that implantation between the embryo and the endometrium. And when this doesn't work, okay, for let's say after one time, we consider it normal, because not all embryos have the potential to implantate, even if there are euploids, that means chromosomically normal. Okay, so not all embryos are able to do this. But obviously, if this happens more than 2 or 3 times with correct blastocyst, correct endometrium, then the recommendation will be to do more tests to see whether there is anything else, let's say immunitary, or sometimes in the blood coagulation that is avoiding this implantation.
And is that part of those tests, is that Pgs testing as well?
The Pgs testing was to see, the chromosomes of the embryo, whether it's normal or not. This is always recommended when there is an implantation failure, obviously. But as well, we have to see these other tests that I've talked about in women. There are blood tests, other endometrium biopsies or hysteroscopy to see also that there are no problems inside the cavity that maybe couldn't be diagnosed with an ultrasound. Also, we can see with a biopsy whether there are infections in the proper endometrium that are asymptomatic and could also cause an implantation failure. So, I mean, there are many, many tests that we will have to do when there is a case of implantation failure.
I know, because obviously money is a massive barrier for many,
Yeah.
But have you seen cases of women that have, experienced repeated implantation failure, but they've kept going and finally it has worked? Because I can imagine that
yes.
after about, if you were to experience 4 or 5 or however many implantation failures, hope is just diminishing fast.
Obviously.
Yeah.
But as everything in life, sometimes we have patients that even if they did not go through all the tests that we are recommending, or we are even not finding anything that tells us, okay, this is the problem, because many, many patients are like this, that we don't have, let's say, response to what's happening. Then sometimes going through more and more treatments, finally they achieve pregnancy. But obviously, and unfortunately, this is not for everyone.
I think one of the key things that I'm going to take away from our conversation today is that don't feel guilty as a woman that you've done something wrong.
Absolutely.
I think that you know, it's very, very important when you say that leading up to your IVF cycle, you know, you want to do everything you can in terms of being healthy and eating well and cutting out everything that isn't great for you. But at this stage, you've done all you can. And I think
absolutely,
yeah.
And that is my advice to all patients, to stay calm, not think that it didn't work because of something they did throughout the treatment. Obviously, that's not the reason.
And for those, and so now on the flip side, if you have the embryo transferred, a lot of women are frightened to do certain things afterwards for fear of, disrupting implantation. So what is not allowed? Is there anything that isn't allowed after a transfer?
Truly, scientifically, we haven't seen that, for example, doing exercise has to be, let's say, or has to avoid an implantation. But obviously, our advice is to stay 3 days after the transfer, a little bit calmed. It doesn't mean that you have to stay laying down or sitting down all day. But obviously, we recommend not to do any exercise or to avoid sexual intercourse during those 3 first days. Mm-hmm. That's all. I mean, apart from that, they can do absolutely normal life. Mm-hmm. Even, I think it's better. My advice is to try and stay distracted, think about something else, so that psychologically maybe they can feel better and not thinking about the same thing all over again.
And is it okay to have a bath?
Okay, at first, yes, but we have to take into account that if they are doing the progesterone treatment with the vaginal pessaries, they should at least wait 2 hours until they take that bath. And as well, we have to take into account the temperature of the bath. Mm-hmm. Because maybe if it's too hot or too cold, maybe it's not so good. Yeah. So try that the temperature is more or less, let's say, atmosphere temperature, at least, and 2 hours after taking the vaginal pessaries.
Yes, I think after my my only successful round, I just didn't move. I was so frightened to do anything that, like, sex was the last thing on my mind anyway. Like, no thanks. And I was just so frightened of baths or anything. So I just wrapped myself in a big duvet and just sort of saw it out, really. But I think that, again, there is that fear, isn't there? That fear that you're just going to do something wrong.
Yeah, I think it's something natural, no?
Yes.
That it happens to all the patients. I think that the best will be to do what really makes you comfortable.
Yeah.
Yes. And that's it. Avoid trying to think about it all the time, because obviously, it's also difficult psychologically to go through that same thinking during 11 days until the pregnancy test. So that's why maybe being distracted would be better.
Yeah. That 2-week wait is possibly the longest 2 weeks you'll ever experience, isn't it?
Really
really, 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 really tough. But hopefully at the end of the 2 weeks, you'll get the miracle,
That's it. Yeah.
Well, look, I know that you have clinic to get back to, and so I won't keep you any longer. But thank you so much. This has just been hugely informative, and I'm sure it will help so many. Thank you.
Thank you to you, Sara. Very nice to be with you today, and hopefully see you soon.
Yes, definitely. We'll do something again soon.
Okay. Bye-bye.